Okay, dear viewers, welcome to my channel. I'm so honored to have two amazing guests for you today. First is Dr. Keith Nichols. He will be on in a few minutes, which if you have been following my channel for a while, you will probably know as one of the best hormone optimization doctors in the community. And second, that you can already see right here, is new to my channel, Dr. Anthony Jay, PhD scientist and author of the amazing book called Estrogeneration. So welcome, Jay.
Please like and subscribe. Thank you.
And hit that notification bell so you won't miss anything.
Thanks for having me, Stephen.
So I should say Anthony or Dr. J. Okay.
Doesn't matter.
Okay.
I like Dr. J sometimes because it's a good brand, because there's a basketball player in the United States that went by Dr. J, so people remember it better.
Okay, Dr. J.
But beyond that, I don't. For you, just call me Anthony.
Okay. Great. Thanks. So first, since you're new to my channel, at least, can you please introduce yourself to the viewers, how you became interested in what you do now, and why you exactly wrote your book, Estrogeneration?
Yeah, I wrote the book mostly because I was interested in this information myself. You know, way back when I was in college, I heard that there's birth control in the water supply. They actually had somebody from the state give a talk at the orientation for college, and that was just a completely new concept for me. I never even thought of that as an option, you know, as something that could be really happening. And I started to look into that, and you know, it just kind of grew and snowballed and became bigger. And I, you know, became a biologist, a biochemist. So I have my PhD in biochemistry, and I did the PhD on cholesterol and hormones and lipids. And then, you know, now I do research with epigenetics and stem cells at the Mayo Clinic. I also do research with infrared. So there's a lot of connections between the stuff I'm doing now and the book I wrote, because, you know, I'm not actively working on estrogen right now, but I'm working on epigenetics. And the reason that's important is because these chemicals, these artificial estrogen chemicals that I wrote the book on and that we'll probably talk about, they act on your epigenetics. They change the marks on your DNA. So they don't change the DNA. You know, they're not causing mutations for the most part. They're not super toxic in the traditional sense that people think of toxicity, but they're toxic in the way they act on the DNA. So they change these marks on top of the DNA. And the biggest problem for that is it's inherited. So when I started having kids and, you know, with my background, I started looking into it, and I realized it's not just birth control. It's not just some of these plastic chemicals. You know, there's a long list of things, and we're exposed every single day. And that's the real problem. It's not just an exposure here and exposure there. It's the daily exposure. So they just start adding on top of each other, and then you get all these health problems we're seeing.
Mm-hmm. Okay. And what would you say are the most common sources of artificial estrogens?
Yeah, it's the most common are coming from the drinking water, and they're coming from the personal care products, in my opinion, depending on where you live and, you know, how healthy you are. But for average people, the drinking water, personal care products. There's a lot of other ones in the, you know, like the fragrances. I include those in the personal care products. The sunscreen, I include those in the personal care products. Now we're making a lot of the sunscreens illegal. Like in Hawaii, for example, in the United States, we recently made sunscreen illegal. And it's not really sunscreen. It's just these chemicals that are found in almost all the sunscreens. They made those illegal because they're killing off the coral reef species. They're causing the fish to become infertile, just like they're causing humans to become infertile. But nobody seems to care too much about the humans becoming infertile. But the fish, they all of a sudden are worried about, right? Because it's a food supply, and it's a beautiful reef. They have pledges in 10 other countries to do the same thing. And they've even found parabens in polar bears in northern Alaska. They find them in sea otters. They find them in whales. They've done studies on different dolphins. So it's working up the food chain, because even the plastic chemicals and the personal care product chemicals, we're flushing those down our drains, and they're ending up in the oceans and working up the food chain.
Mm-hmm. So being a dermatologist myself and recommending patients every day long to use these sunscreens, are there any safe ones?
Yeah, I'd recommend zinc. So 20% zinc.
So
you
that's
know.
just the typical mineral sunscreens without any filters.
Correct, without the chemical benzophenones or oxybenzones. One's called 4-methylbenzaldine camphor. I'm not a fan of because it acts like estrogen. They even use these in a lot of clothing detergents, laundry detergents, because they protect your clothing from getting fading from the sunshine. But again, they've done studies and they show that your skin takes it up. So even just wearing the clothing, this Keith, wearing the clothing causes uptake through your skin, and it's enough to be substantial, significant.
Mm-hmm. I know each brand of sunscreen has its typical mineral sunscreens with just titanium oxide, whatever, zinc in it. It gives a kind of whitish color to the skin, and that's why all these other filters are so popular, of course. So
right.
There's not one.
Well, I was going to say, I mean, I've done some studies with titanium here at the Mayo Clinic, and it's taken up by the cells, and we're just looking at it with the electron microscope, and we haven't published this data, but I have seen the data. You see titanium clusters being set aside inside the cells. The cells just don't know what to do with it. They're basically storing it away in these little, and they're endocytosing the titanium. But it looks to me like they're just clogging up the cells, the titanium. So it's not super toxic in the traditional sense, but I'd like to see people use zinc because, it's pretty, obviously it's natural. A lot of people need zinc. If you're taking that up through your skin, that's perfectly fine. And the other thing is, you can find varieties that don't make your skin super white. It's hard to do. It's hard to find them, but they are out there.
Okay, I'll keep that in mind, and I'll keep an eye open for them. I'll ask the representatives that come into my office for their sunscreens. I'll talk about what you just said.
Yeah.
Okay.
Well, and I know Keith was just bringing up, just as he was jumping on, he was talking about this YouTube video, with the sunscreen chemicals that block your androgen receptor binding. So one of them is called 4-methylbenzaldine camphor. I usually just call it 4-MBC because it's a hard name to pronounce, but they've done studies directly on that sunscreen chemical, and they find that it blocks your testosterone from binding the receptor. And so that's a real problem. And I think a lot of these estrogen chemicals do that, but not a lot of people are studying that because it's so difficult to study. You have to take biopsies. You have to tag these receptors. You have to do a lot of hard biochemistry. So it's expensive. It's basically just research stuff. It's not something you would do in a clinic, or not something you would have your patients do. But it's a real thing, and it really happens, and it's a lot more common than people realize with all these estrogen chemicals, right? And one of the things, what I'm basically saying is these estrogen chemicals they're going through your blood, they're coming in contact with the receptor, and they're actually blocking the ability for the receptor to bind to testosterone, right? So the analogy I use in that YouTube video is hockey, or any sport. You could basically take some other sport like cricket, or I don't know how to play cricket, so I just use hockey, but it's effectively the same as blocking off the goal, right? So if you put a piece of plywood or a board in front of the goal so you can't even score, it doesn't matter how many players you have on the ice or how many players you have on your team, how many pucks you're using, how much shots you have on net, you can't score. Testosterone can't work even if it's super high because the receptor is being blocked. And again, this happens with a lot of these chemicals, but it's almost impossible to test,
That's the point I try to get across to patients, and we keep getting this question over and over again is how do you know this? Well, Anthony, I try to explain that we are in the infancy of understanding EDCs. The way we test for them using normal toxicology methods don't work. We know that they have a non-monotonic response, meaning that the dose doesn't make the poison. I mean, low dose exposure for extended period of time can cause some dramatically bad effects on people. So the problem is we're just in the beginning of understanding. I mean, there's over at least 85,000 chemicals and or more, and most are not tested. So we really don't know how they act on our bodies. We do know there are plenty of endocrine disrupting chemicals, as Anthony's well aware of. But one other thing that complicates everything is that we don't know how they act in concert with each other. They may be, non-toxic by themselves, but you put them in combination with others because we're exposed to these EDCs in combination every day. So, when we get down to the nuts and bolts of things, Anthony's analogy of the hockey players is very good. I try to explain to my patients that I'm trying to outcompete those EDCs for the androgen receptor. The EDCs are there. What I like about Anthony's videos, he's usually having some articles that he'll point out to people that he's reading from, especially with the sunscreen video, which is very good. So, with regard to hockey players, if the other team has 10 players and you have 5, it's going to be hard to score a goal. So, but if I give my team 10 players or 15 players, we have a better chance of getting that puck in the net, therefore exerting a response. So I'm out competing that, but how can we prove that? As Anthony said, it's in its infancy. You can't study it from a clinical standpoint when we're treating patients. So how do we treat?
Exactly.
We treat based on symptoms. So I have to treat based on symptoms. And so that's basically what they're calling now functional hypogonadism, which are men with normal levels that have symptoms of hypogonadism. Because, we know there's no biological parameter that denotes a deficiency. So that's why I wanted Anthony on, because he is an expert in these EDCs, especially with the estrogens. But as we know, they're affecting the thyroid receptors, the androgen receptors, the estrogen receptors. They mimic the hormones, or they antagonize the receptor. So,
Yeah, right.
Guys want to say, where's the proof? Here's endocrine disruption of androgen activity by fluoroalkyl substances, clinical and experimental evidence. I mean, we can do paper after paper.
Right.
Disruption of receptor signaling in males by environmental chemicals. The studies are there and there and there. Endocrine disrupting chemicals and disease susceptibility. I'll make all these available under Stephen's podcast here for people to review. It's not the most pleasant of reading, I would say, would you, Anthony, when you're reading about these chemicals. But I really wanted Anthony to be able to talk to explain from a researcher standpoint of why I need to do what I do from a clinical standpoint.
Right. Well, let me just talk about a few of those things, because there's a lot there. And, if you go back, and I do this in my book briefly, but if you go back thousands of years, you actually start to see feminization occur just in our bone structures. So we actually had decreasing testosterone occurring thousands of years ago. And I personally think that had to do with the increase of eating a lot of plants, because some plants have some of these estrogen chemicals. But the feminization was just tiny compared to what it is now today. And in the last 30, 40, 50 years, it's just been almost exponentially increasing this, the lack of response to testosterone, the testosterone deficiency syndromes, this feminization of males. There's problems with females, of course, as well. It's not just a male specific problem. Even female testosterone is dropping, and so that real rapid increase and expansion of the problems, I think it's related to these artificial estrogens. I mean, the proof is really there. It's just trying to define all the subtle details that's become kind of complicated. For example, BPA is an estrogenic chemical. BPS, BPF, BPAF, those are just some of the bisphenols. But then you got the phthalates, right? Like diethyl phthalate. There's parabens, there's methylparaben, propylparaben, butylparaben, right? You can just list all the, and like just going into the phthalates, for example, even, you can list like the 8 most common phthalates, right? And these are found in personal care products. They're found in the plastics. They're leaching into water at room temperature at really high doses. And I mean, high relative to our natural testosterone levels and our natural estrogen levels. And if you're just studying those 8 phthalates, it's kind of scary, right? But then those phthalates get broken down into dozens of other products, and those can also act to block your testosterone, your androgen receptor. And so then you've got to study the metabolites of the phthalates, right? And it just kind of snowballs into this big problem. So I think what the future is going to be, it's going to be looking at the epigenetic changes, and we're going to have the technology to do that. We just don't right now. So right now you definitely have to go with the symptoms.
Mm-hmm. And to come back to the term male feminization, are men more under attack by our environment than women for the moment? What's your opinion on that?
It's hard to say because I think we're equally under attack, but the outcomes are different. For example, women are going into puberty earlier and earlier and earlier because of these artificial estrogens. So that's a one way of looking at this attack and this issue with artificial estrogens. Whereas men, we've got our whole other list of issues. So it's kind of separate categories of issues, but they're both uniquely problematic, and trying to quantify how problematic it is. I mean, like just looking at fertility, for example, one of the unique things is, even women that are getting these artificial estrogens are becoming infertile. Men are also becoming infertile, and it's not even just us that are being exposed, it's the next generation, and it's the next generation after that. And you see a good example of that in this chemical diethylstilbestrol. It used to be a prescription drug. They prescribed it for like 30 years. And it's like a lot of people call it DES or just DES. And it was a morning sickness drug, but it mimics estrogen. And it caused, the mothers, they thought it was fine. The doctors thought it was fine. Again, professionally prescribed. And so, everybody was seeing it as a fine, perfectly good thing to prevent or, quote unquote, cure morning sickness. And then all these offspring had issues. Not all of them, but a huge percentage of the offspring had real noticeable, obvious differences. And then the offspring of those offspring. So even in human studies, right? And that's not to mention the animal studies, which are crystal clear that there's increasing fertility at least up to 4 generations in mice, and in fish, and in all these other species. They kind of say it just crosses all the species. So it's just almost impossible to do those studies on humans right now. Just how long their lifespans are.
And before we start talking about optimizing our hormones, one more thing. You mentioned, Anthony, are there in Europe less EDCs than in the United States?
For sure, yeah. And that's one of the reasons I think, that people are healthier over there. It's really interesting, and it's not, proof of causation, but in Europe, the regulations are far stricter than the US, and they're even stricter than the UK, and then there's America, which is not strict at all.
Right.
And if you look at the health, Europe is a lot healthier, just in terms of obesity, which, by the way, these chemicals also trigger obesity. If you look at the health of Europe compared to the UK, compared to America, it's just in that order in terms of obesity, right? Just using that as a metric. And, one of these some of these are even more illegal in China. China has even stricter regulations on the parabens, for example, than America. And a lot of it is just politics, right? Like in America, the politicians are being bought out by these chemical corporations, and there's a lot of influence behind the scenes. Whereas in Europe, I know a guy, his name is Michael Skinner. If people want to look him up, he's a great scientist. He studies endocrine disrupting chemicals in multi-generations of mice. He has about 3,000 mice right now that are growing. I've talked to this guy at the Mayo Clinic here. He's out in Washington State. But he gave a talk over in Europe about this fungicide that people spray on their fruits and vegetables. And 2 weeks after he gave this talk, and of course it was showing all these problems that are not only affecting people exposed or animals that are exposed to the fungicide, this spray, this chemical spray, but the next generations that are affected and how problematic that is, because it actually gets worse in the next generations. It's like almost nothing in the first generation, and then it actually gets worse and worse, at least in the mice. He gave the talk in Europe, in Germany, and 2 weeks later they had that chemical was outlawed. And by the way, this talk was like 6 or 7 years ago. It's still legal here in the United States. We still spray that particular chemical on our products.
Okay, amazing. Okay, so let's talk optimizing hormones now. One thing I wonder about, previous generations did probably not need to worry about this, right? And why do they now? What changed in a few generations?
Yeah, it's just the ability to manufacture these artificial chemicals. I mean, you could just blame it on the plastics, but that would be too restrictive because, like I said, we already talked about the sunscreens, right? I mean, they're adding some of these chemicals that are similar to estrogen to the sunscreens. And if you just tried to limit to that, you'd be forgetting about the personal care products, which we're rubbing on our skins. Oftentimes they use the word fragrance on the ingredient label. And I don't know what the status is in Europe in terms of doing this, but in America, they're allowed to put all these chemicals together and not reveal what they are on the label because it's proprietary. It's their secret formula. So they're able to say perfume or fragrance on the ingredient. And what that means is a bunch of artificial estrogen chemicals. They use them as fillers. They're cheap. And honestly, they're attractive. I mean, they smell like estrogen, right? So they actually do trigger a positive response in our brain. Like the new car smell is a good example. That new car smell is one of these sunscreen and plastic chemicals. It's a combination of phthalates and benzophenone 3. And so, it's giving us this positive association because we're wired to be attracted to estrogen, and it's obviously just bastardizing the whole process within our body.
Okay. I have an American car and it came with a nice smell last year.
Yeah.
So, damn.
Exactly. Yeah. And I mean, there's always going to be some exposures. We live in this world where there's just so many exposures. The key is to limit it. But even when you limit it, oftentimes what your parents did at this point is affecting your testosterone, right? And affecting your children's testosterone. So a lot of times, even with the most strict, plans to avoid these artificial estrogen chemicals, you're still going to struggle. It's better to optimize your testosterone because, you're able to unscratch that CD. And one of the nice things about testosterone and a lot of these sex hormones, including estrogen, they actually go through the nuclear receptor. So if people can imagine a cell, like a ball, it's got a membrane to protect the cell from things just going in and wreaking havoc. So it has a membrane, and of course, estrogen, testosterone, artificial estrogens, they can go through that membrane. They're able to be transported in, or they just diffuse in, and then they're inside the cell. And you can do a lot of damage just getting things inside cells that are artificial like this. But what makes it even worse in the case of these sex hormones is they can get into the nucleus. The nucleus, where the DNA is, also has its own membrane. So it has a special extra rigid membrane, it's just another way of regulating to make sure nothing's going in and wrecking your DNA. But with these sex hormones, they're allowed to go into that membrane. They're allowed to get in and tinker with your DNA. Again, kind of like unscratching your CD. You scratch up your CD. For those of you who remember what CDs are at this point and listening to music on CDs, if you scratch that, that's going to be a big problem every time it comes around. But unscratching it, you can imagine, is real difficult. But these sex hormones are able to do that to some degree because they're in there. What do the artificial estrogens do? Same thing. They go into the nucleus and they're able to cause these problems. So that's why I really like testosterone, because you're able to unscratch the CD at least to some degree.
Okay, so great. That's the moment to start talking about our TRT. So I have discussed this point repeatedly with Dr. Nichols, and that's exactly why he wanted to bring on Dr. J to explain to us the safety and the reason we need the dosages we need nowadays with regards to testosterone optimization. So talk about that, Anthony.
Oh, yeah, for sure. I mean, I think the natural levels that our ancestors had, were probably in the thousands. Total, I'm just talking total testosterone right now. And of course, there's a big problem with free too, because these estrogen chemicals, not only do they lower your total testosterone, they lower your free testosterone by increasing SHBG, sex hormone binding globulin, and they block binding to the receptor. So you kind of have this triple, layered problem. Three problems. Total is dropping, free is dropping, and the stuff that you finally do have left over is being blocked. Just going back to that sports analogy, the hockey analogy, for people that know about hockey and understand the sport. So that's why you have to go with symptoms, because no doctor is going to take a piece of your cell or a piece of your tissue and actually check how many receptors you have there. And even if they do, you might have a lot of estrogen stored up in your fat tissue compared to the next person. You might not have any, there's so much variation there. these chemicals aren't causing toxicity in the sense they're not killing your cells, but they are storing inside of your cells and they're causing these health problems. Infertility is a good example, depression, because they act in your brain, and that's one of the reasons with testosterone optimization, for example, people have a lot more, mental acuity, their cognition goes up, and you could just go on and on. I mean, Keith could probably speak to a lot of the positive benefits of testosterone optimization and which ones he most commonly sees, but I mean, there's a lot.
Sure. And we are trying to treat on symptoms, but once again, traditional medicine is treating on a number, and that number has been significantly reduced. And as we've talked about, there's no specific number that denotes a deficiency. These numbers were made up by men. And in an effort to really restrict its use, the FDA has come down on the Endocrine Society to essentially, to restrict its use. So now we have these lower numbers, and as Anthony knows, the papers they're written. Travison wrote the paper, at least 2 of them, where we know that environmental factors are contributing to this decline in our testosterone levels as well as our sperm levels. The Endocrine Society itself has its own section on EDCs, and they have their own paper that they wrote about the fact that all these abnormalities that we are seeing in the male and female reproductive systems and other areas directly correlate with this increase in the industrial chemicals, the phthalates, the pesticides, the herbicides. So we know there's a direct correlation. Earlier in our podcast, we discussed how difficult it is to test and that almost how impossible it is, and the fact that most of them are not tested. So the only way that I know to treat a man that has classic symptoms of hypogonadism, I mean, he has, joint pain, muscular aches, general feeling of a lack of general feeling of well-being, irritability, physical exhaustion, fatigue is a big one, erectile dysfunction, lack of morning erections. I mean, the list goes on, and we treat toward those symptoms. And unfortunately, we measure a number, and interestingly enough, in all the guidelines, they don't tell you even when to measure that number. They just say measure a number. They don't tell you to measure it. If you do injections right after the injection, 3 days after the injection, or when you apply a cream, do you test it 1 hour later or 24 hours later? So they don't give you any direction with regard to when the test. So we treat toward numbers, but what I'm finding is that these younger men, and I do believe it's what Anthony has pointed out earlier, it was the exposure during fetal development. At that time, within the last 30 or so years, that's whenever we've come out with the non-stick frying pans. But, we all came out with microwavable plastics, and that leaches into our foods. And I do think it's affecting these men because you just have man after man after man coming in their low and mid 30s and early 40s. And you didn't see that 20 and 30 years ago. You just didn't see it. So our numbers are being lowered, but our needs, and this is what I try to get across, our needs have not diminished.
Yeah, in fact, probably a lot of 20-year-olds are coming in, with these symptoms. They just don't have the money to actually even consider, or the wherewithal to consider what's really happening. I mean, it's really frustrating.
So let's make sure that, we all assume that we don't even assume. We've excluded, smoking, obesity. Let's exclude all lifestyle factors. We've gone through all that. We're dealing with a man that's done everything he can do to improve his life, and he still has these symptoms. And it's been proven that you can take a morbidly obese man or obese man, he can lose a significant amount of weight, and it's still not going to raise his testosterone levels enough to exert any significant effect. So what we have to do is treat the men with symptoms until those symptoms improve. And we don't treat toward a number, but what we are seeing is that men that, come in with a level of 200 and 300, that putting them sometimes at 600 and 700 just doesn't do it. It just doesn't do it.
Right.
So we run into this dilemma. Do you stop treatment? You didn't get better at 700. You should be, because that's mid-normal range. In fact, the normative value is 916 now. It was over 1100 2 years ago, but they keep coming down. So you either have to treat the piece of paper or the number on the piece of paper, therefore ignore the patient, or you have to treat the patient. And once again, what I factor in, and why I'm love that Anthony is here today, is I'm also factoring in what I'm dealing with at the cellular level. How much, resistance am I dealing with at the cellular level from their toxic exposure? I can't measure it. Anthony can't measure it. We don't have a way of doing that right now. The only way that I know to help these men is to treat them with an adequate amount of testosterone. What is an adequate amount? What improves their symptoms? Do I have men 2, 3, 4,000? Absolutely not. We're not talking about testosterone abuse. We're talking about treating to an effect.
Right. Yeah, and there's such clear evidence. Even the receptors numbers are dropping. If you're actually going so far as to take biopsies and actually counting receptors using fluorescent tags and things like this, I mean, they are going down. But again, it's impractical. You can't do that in a clinic. And when we do those kind of studies at the Mayo Clinic in our research labs, it's even more complicated than just taking out a biopsy, as I was telling you on the phone, Keith, because if you just take out one biopsy, and then you take out another biopsy, sometimes those two biopsies right next to each other have different numbers. So what you have to do is literally take about 10 biopsies before you get, a value that you can really, get a grasp on what's going on with their testosterone receptor number. Obviously, that's not practical in a research environment. Even in a research environment, we're humans, right? Nobody wants to get 10 holes punched into their arm to measure testosterone numbers. And even if you were, that doesn't automatically give you the perfect number for dosage for testosterone, right? I mean, it's a tricky situation without having the technology to measure epigenetics. And again, that's coming down the road. I mean, probably the next 10 years or so, we'll have really good markers that are just based on the DNA marks and how to fix those. Hopefully 10 years. I'm being optimistic because these things usually start off really, really expensive. I've looked into having my epigenetic sequence done just for the methylations, and it was $20,000 just for me, so it's obviously not there in terms of affordability. And even if I had mine done, I wouldn't know a lot about what to do with that, because you need other studies from other people in other unique situations with low testosterone, with high testosterone, with low estrogen, with high estrogen, to get a sense of how these marks on your DNA are changing and what that change means.
Well, I would also encourage everyone to go to the actual Endocrine Society's website, and all the guidelines are there for the various disorders, and they do have an EDC section. I encourage you to look at that Endocrine Disrupting Chemicals section and about the havoc that they know that it's wreaking on the endocrine system, but yet that havoc has not yet entered or factored into any of the guidelines that are being written, even though it's on their own website.
Right.
So that's what I find amazing.
Mm-hmm.
Exactly.
So what about the problem if we really need to make the symptoms disappear, that we first have to reach certain numbers of total testosterone that seem for others supraphysiologic? For example, 1500 nanograms per deciliter. These seem supraphysiologic, but then again, previous generations had that as normal levels probably. What about the legal issues and trying to optimize levels to that level?
That would be
Anthony.
more with legal issues. I mean, it always comes back to fighting the powers to be in terms of money, And I mean, I'm not a super issue on the legal issue. I'm not an expert on the legal issues in the medical realm. I just try and educate people on the best way to, optimize their health, and what's going on at the cell level, how these chemicals are disrupting. I mean, I think right now you have to take matters into your own hands, because there's not going to be, a government board or some people in the government or something that are going to take care of you in your situation. Again, because of the influence of money, it's making it, kind of messy in the United States.
We have talked before about testosterone resistance. Do the endocrine societies already have done something with that?
No, that's what we're talking about. Even though they'll mention in their guidelines that resistance can have an effect on a man's testosterone, they still don't factor that in to the guidelines. In order to meet criteria, you have to have a low number, less than 300, let's say, plus symptoms and signs, so that they do not yet recognize what's being termed now functional hypogonadism. But I will refer everyone to a paper, and I'll include it into your once again, I'll send it to you so you can add it for people to look at. But it was sent by Dr. Rouzier. He's done a podcast on it, and it was in the Aging Male. And I also have most of the articles that are referenced that are important, especially one by Bazin. They gave multiple doses of testosterone. One of the doses actually got men's testosterone up to around 1,600, and those men did very well. Body fat decreased, skeletal muscle mass increased, no significant adverse effects. When they did get over they gave men dosages that got them into the 3,000s. The major adverse effects that occurred there were edema or hematocrit increase. But even with men that they got levels above 3,000, there were no major adverse cardiac events noted. So they also reference other papers where being 950 or higher has been safe and effective. So this is from the Aging Male, and it's called Important Lessons About Testosterone Therapy, Weight Loss versus Testosterone Therapy for Symptom Resolution, Classical versus Functional Hypogonadism, and Short-Term versus Lifelong Testosterone Therapy. So I'll encourage everyone to read that article, look at the one by Bazin. I will also include the article by Bazin, which is this article here. So it's something that you should have as part of your library to support treating symptoms and showing that a number that may be above 400 or 500, which is the mid-range of normal now, would be indicated in a symptomatic man.
Mm-hmm. Okay, thank you. Very interesting paper, probably. If optimizing our hormones is the best thing we can do to protect ourselves from EDCs, what other hormones do we also have to optimize, Anthony? Are the other hormones like thyroid, for example, also affected by these EDCs?
Sometimes, yeah. I mean, like for example, soy usually has an impact on your thyroid gland. But what I tried to focus on in my book were the common threads or the common themes between all these chemicals, right? So when you look at phthalates, you look at parabens, you look at BPA, you look at some of the mold estrogens. So molds can secrete estrogen chemicals. You look at, some of these other classes of artificial estrogens, including the plant estrogens. You find real common health problems among all of them, right? Like if they've studied infertility, you find infertility. Sometimes they haven't studied it. So of course you're not going to find it if they haven't even studied it or investigated it. But but the thyroid is hit or miss in terms of some of these estrogen chemicals. Sometimes they alter your thyroid, sometimes they don't. But it's definitely something that people should pay attention to. And there's some genes, some genetic differences between people that oftentimes I see connected with actual thyroid issues. So if you've got some genes relating to, like if your thyroglobulin gene, there's a couple of them. There's 3 or 4 different genes that are fairly predictive of having thyroid issues in our culture today, at least. But yeah, it's definitely worth keeping an eye on all your other important hormones and even your blood sugar and all that, of course. But absolutely.
Mm-hmm. From the practical side, Keith, what hormones do you want to see optimized in men if they come in with low testosterone? Do you optimize all hormones at once?
I do. I certainly do.
Is this also in the view from protecting from EDCs?
Well, that's for preventative medicine. We're trying to obtain levels that are in the upper range of normal for our young individuals so that we can have all the protective effects of those individual hormones, since they all have their individual protective properties. So we're trying to maintain them at young, youthful levels. Because as we age, they decline with us. Our hormones decline with us. Now, we're not talking about treating 18, 19, and 21-year-olds. We're talking about treating middle-aged men and older.
Mm-hmm. Okay. I see a lot of men, even friends that I know, with reproductive health problems, low sperm counts, not being able to have kids, and so on. Is this all because of the EDCs, Anthony?
I mean, not necessarily. You might be putting your laptop on your lap, and you might be, like overheating your testes. There's a lot of different. You might just be obese, for other reasons. I mean, there's so many things. You might have heavy metals, sometimes people have genetic issues where they're not clearing heavy metals. Some people have perfect genetics, but they're exposing themselves to a lot of heavy metals, which obviously can, interact with your sperm production and your sperm producing cells, your Leydig cells and all this. I mean, there's a lot of multivariable, potential issues that are worth looking at, especially for somebody like Keith or myself. We're definitely thinking about those things because, you don't want to give somebody testosterone when they're just eating a can of tuna every day and they've got high mercury, right? Because they're going to continue ingesting high mercury, and that's obviously going to lead to other disorders and other problems that the testosterone is not going to fix. So all that stuff has to be factored in, but it's always a case-by-case situation.
I know for sure if those men that I'm talking about go to these reproductive clinics or to the gynecologist together with their woman, they're not talking about EDCs, that I'm sure of. They're always talking about just trying to fix things and giving this kind of treatments really. So what should change? And is the same thing going on in the United States? Is nobody talking about EDCs in this kind of reproductive clinics?
Usually not. Yeah. Usually they're just, doing IVF and these kind of things right off the bat. I mean, it's a financially driven system, right? So you're not going to make money by, telling people to avoid plastics and avoid all these things. I personally get testimonials where people have been struggling with infertility for 10 years or whatever, and they clear all of their estrogen chemicals and they suddenly become fertile doing nothing else, no other differences, no going to clinics. It definitely happens, and people contact me and tell me about that. So I think that's a really important strategy, obviously, to get rid of these estrogen chemicals before, going on optimization therapy and before going to these clinics. And, you can do a lot within 6 months. Like, for example, going to a sauna really helps. That increases the rate of excretion, even from your skin. They've done skin patch testing where they put it's like a nicotine patch, but without the nicotine. And they measure, people that are going in saunas, and before you go in the sauna, you're not getting rid of these chemicals, but when you're going in the sauna, you're sweating a lot of BPA, you're sweating a lot of phthalates, you're sweating these chemicals out. So you can expedite the process, by just eating healthy, avoiding them, and sweating.
Mm-hmm. And losing fat, probably.
Oh, for sure, because it stores in fat. Yeah.
It's one of the main reasons I wanted to have this conversation today, is to hopefully at some point in time it becomes at least a thought process for treating physicians to consider EDCs as a source of their male or female's symptomatology when they do see them, and they have excluded other lifestyle factors. They don't smoke, they do have a good diet, they do exercise, they do all the things that they can do, but yet they're still extremely symptomatic. And so, yes, we see the EDCs affecting the estrogen receptors, as Anthony is the biggest expert in the world on, probably. They do definitely affect the thyroid significantly. And of course, my focus is more on the androgen receptors. And yes, in all these studies that I pointed out earlier, when they just looking at this one substance that's found in carpets and, water repellents and cookware. I mean, yeah, it's shown to decrease semen quality, testicular volume, penile length, and anogenital distance. So they're there, and we're exposed to them. And I just hope that physicians will keep that in mind when they're treating patients.
Okay, thank you, Keith. Maybe to end this interview, one more question, Anthony. In your opinion, are these EDCs a threat to humanity, really? How do you see that? Are you a bit pessimistic about our future as humans?
I think so. I mean, they're definitely a threat to humanity, but it's just, there's always going to be people that are avoiding them, and there's always going to be people that are smart enough to decrease their exposures and to stay healthy. So I don't think we're going to have a complete population wipeout, but you never know. I mean, certainly in animal populations with animal research, you can do that with the types of exposures that we're getting. And the biggest concern is the combinations, like Keith mentioned earlier, right off the bat, right? If it was just the BPA, I wouldn't be that concerned. If it was just the phthalates, I wouldn't be that concerned, although I probably would still be pretty concerned. But because it's, literally 10 different chemicals that are acting like estrogen pretty much every single day on most Americans. And in Europe, it's probably about 5 different chemicals that are acting on everybody every single day, because a lot of them are illegal. But yeah, it's a concern, and it's kind of like the health span versus lifespan discussion, where people want to live longer, but sometimes living longer isn't necessarily optimal, because if you're sitting in a wheelchair and all you can do is just stare out the window, you can't even move for 10 years. Nobody really wants that either. That's not the goal. People want to live healthier. And so just looking at it from a population perspective, it should be framed the same way. We shouldn't want our whole population to just survive. We should want our whole entire global population to thrive. And that includes the nature, that includes the wildlife, and especially us as humans, of course.
Anthony just hit the nail on the head. The whole goal, the entire goal of hormone optimization is to improve the health span, to prolong the health span, not necessarily lifespan, but the health span. That's what we're looking to do.
Okay, great message to end on. So thank you both for your time and this amazing interview. Maybe to end, Dr. J, how can people follow you if they would want to? Maybe your social media or your YouTube channel?
Yeah, certainly. My YouTube is called Chagrin and Tonic, because that's part of my book series I'm coming out with. So the Estrogeneration book, it's part of a series that I'm hoping to come out with. Of course, I'm so busy, it's a slow process writing these books, because I like to do a lot of research, and there's 400 references just in the Estrogeneration book. But certainly YouTube's a great place, and I'm also on Instagram and Twitter and things like that.
You still have a convertible Mustang? You still driving?
Oh, the Mustang? No, but I'm in the business. I'm looking for a truck now, because I live in Minnesota now. I've moved.
There you go.
Okay, thanks as well, Keith. And how can people reach you if they would want to work with you?
They can reach us at wellness@tier1hw.com.
Okay, thank you so much, both of you, for your time. And talk
Thanks.
to you another time. Thanks.